let's talk about ethics. Um, Although ethics are have some what of a legal aspect, most are solved in the field and not in a courtroom. Um, ethical issues often begin with specific circumstances that lead to broad general rules or principles of behavior. Um, there are times that ethical problems will lead into court or into a legal issue, mediation of some sort, something like that. They become the subject of legislation or regulation, is usually what happens. The feds, for example, recently instituted rules to protect patients who are unable to consent to emergency care. We have some, they've altered them a little bit. Ethical issues often begin with specific circumstances, lead to broad rule and regulation changes for principles of behavior and how we react to things in the field, or in our instances, how we react to things in the field. And we'll talk about more in this chapter as we go. Um, Ethics and morals are very closely related, however, they are different. Morals are social, religious, or personal standards of right and wrong, whereas ethics is more of a philosophy. It is a branch of philosophy, and it addresses the questions about morality. It goes further than this is wrong and this is right, but okay, what makes this wrong? What makes this right? It broadens the scope of what you're looking at, and pushes those things. And ethics are generally referred to as rules or standards that govern the conduct of members of a particular group or profession and how institutions should function. So, if you think about it, we have the EMS Code of Ethics that we discussed in one of the earlier lectures. We have, or the American College of Surgeons has a code of ethics for themselves. The Board of Nursing has a code of ethics for nursing. The Association of Trauma Nurses has a code of ethics for trauma nurses. The American College of Trauma Surgeons has a code of ethics for themselves. Everybody has their own code of ethics and rules by which they want their organization to run by. And they've examined through over the years and through their research and through their morals of the people that developed this rule of ethics, have looked into what makes this right, what makes this wrong, and have developed the rules and standards for which they want their membership to abide by. The relationship of ethics to law and religion, ethics is not the same as law. Law is very specific. They have a narrower focus than ethics, and laws frequently describe what is wrong in the eyes of society. And as I said earlier, ethics goes beyond examining what is wrong, but it also looks at what is right or good behavior. As a result, law frequently has little to nothing to say about an ethical problem. It's focused more on what is right, what is wrong, at the time. If you think about it, laws can be very unethical. As the book uses as an example, let's look at the racial segregation laws that were present in the United States for decades. Ethically wrong, legally at the time they were correct. So law and ethics are not the same. Even though they're different, ethical decisions can be sometimes benefit from techniques developed by the law over the centuries. In particular, the law emphasizes impartiality, consistent procedures, and methods to identify and balance the conflicting interest. So, as I said, with each individual organization has had their own code of ethics. they have looked back at their past and what they have done to get to where they are. What was right, what was good, what was not right, what was bad, what is bad behavior. Um, think of all the good that came from the 1800s. Medical doctors in Europe would pay grave robbers to steal a fresh corpse from the graveyard so that they could dissect it and examine it and learn from that. So look at all the good that actually came from it, but was that the right thing to do? So we don't pay grave robbers to steal bodies from the graveyards anymore. People donate their bodies. We give them that option. I mean, this is a very basic, very general overview, but you get the idea. Ethics are a little bit more pulled to religion, or pulled from religion, but it differs from it in a pluralistic society, or as many people as we have within our society that are from different backgrounds, different belief structures, different theologies. Ethics must be understood and applied to all people that hold a range of beliefs all across that board. You may not even be religious. You may be atheist and not believe in anyone or be spiritual in any way, but you have a sense of right and wrong. So ethics has to speak to all people from all beliefs or lack of beliefs in that all the way across the board. Religion can enhance and enrich the ethical values, but it does not. One single religion does not drive those. Does not drive one's ethics. In making decisions, here we got a kind of an overview. We saw this before on EMS and public health, medical, and emergency response. Now we have the same type of graph with the same crossovers, and we are somewhere in the middle there. Our ethics and legal issues and medicine all kind of in this small little area right there in the middle. So when we're going into making ethical decisions, ethical relativism, each person must decide how to behave, and whatever decision that person makes is okay. So you have to be okay with the decision you're making. And how it's going to affect you and your behavior. Ethics and morality tend to overlap a little bit as well. And our professional ethics go even further beyond what one individual thinks is right and wrong. People sometimes say that they believe in ethical relativism. However, when questioned, they typically admit that they do not find it satisfactory. For example, no reasonable person would say that it was acceptable for the Nazis, especially the Nazi physicians, to behave as they did. Working, they performed experiments on, most notably on people in the concentration camps. They experimented on how do certain chemicals react for biological warfare. They took twins that were thought to be identical in every way, and they would subject one twin to torture and removing of organs and or adding chemicals into the blood, introducing them into the bloodstream or into the brain to see how they would react as compared to the control twin who just sat there and watched their brother or sister be tortured. So again, a lot of good research came out of that, but was it the right thing? Was it the right way to do it? No, it was not. Similar approaches to say just do what is right. sounds fine, but in reality, it does not answer the question of how healthcare professionals should act. Because people have different beliefs about what is right. Ethics and morality overlap, but professional ethics goes beyond that, as we were talking. Even the golden rule, do unto others as you would have do unto you, is not making a sufficient guideline. What happens when the person making the decision has desires and values that are radically different from the patient's? It becomes clear that reason and logic must be used, and emotion must be excluded from the possible, as much as possible, from the decision-making process. We need to separate ourselves and decide, overall, what is right, what is wrong. Is what I want to do right, or do I need to listen to the patient? I may not agree with what's going on personally, but as guided by the code of ethics of the EMS and of the healthcare profession, they may be right on line. Another simple approach is just follow the Ten Commandments. Although the Ten Commandments are useful, they don't provide enough guidance for medical professionals. Let's think about it. Those of us that are familiar with the Ten Commandments in and out has absolutely nothing to do with the medical profession, and they are considered God's law. They are not even a code of ethics. Yes, I guess loosely you could call them that, but they are described as God's law, and therefore must be acted on as they are law. Within that belief structure, anyway. Very different approach is consequentialism. Followers of this school of thought believe that the actions can be judged as good or bad only after we know the consequences of those actions. Utilitarians, who believe that the purpose of an action should be to bring about the greatest happiness to the greatest number of people, are consequentialists. One difficulty with utilitarians' approach is determining what constitutes happiness. Other challenges arise when the happiness of one person is in conflict with happiness of another person. Utilitarianism offers a bank book approach to resolving these conflicts, asking the decision maker to weigh relative amounts of happiness. So, can you live with this decision? There you start to make bargains to get the greatest amount of good out of it. Well, that's not necessarily a good way of doing things either. Then the deontological method, people should just fulfill their duties. Well, what guides you to doing your duties? There may be the person that believes that it's morally and ethically right to not treat a murder suspect that has been shot while trying to be apprehended, or they just feel like they shouldn't have to treat them at all, just let them die because that's what they earned. But that's not what we do. That's not what we're here for. We may not like it, but that's not our job to decide. Consequentialism, we went over a little bit. So over the years, a number of organizations drafted their code of ethics, as we talked about. All the different organizations that have their own code of ethics all say reasonably the same things as the other. However, they are all different in their own way because they practice medicine differently than we do. Code of ethics often cover these areas: honesty, objectivity, integrity, carefulness, openness, legality, confidentiality, responsible publication, responsible mentoring, respect for colleagues, social responsibility, non-discrimination, competence, respect for intellectual property, and human subjects protection. The impacts of ethics on individual practices. Paramedics exemplify principles and values of a profession. Only by consistently displaying ethical behavior. Now think about how different we all are and all behave and all act. If we could pull together, it becomes the old "we don't ever get what we want" argument. EMS is the redheaded stepchild. We're the newest kid on the block, so nobody knows how to treat us. A lot of that we bring on ourselves because we are not unified. Everybody's got their own agenda that they want to push, and each group has its own agenda that they want to push, and there's very, very little across the board unity of the paramedic and EMS fields. Think about the fire union. They've got a 200 and some year history. And they're all out for, and the IAFF is the largest fire union, and they are out to unify the drive for the fire department and their resources and their compensation and their treatment and otherwise. EMS does not have, we do have unions, but again, we're young, we don't have the unified voice that everybody else does. And I'm getting off on a whole different tangent, but that's part of our problem is we have a lot of egos yet that need, not to say that the others don't, but they've learned how to channel all that into something productive. It's vital that individual paramedics exemplify the principles and values of their profession. Paramedics must understand and agree to abide by those responsibilities, both implicit and explicit, of their profession. Occasionally, this can be a problem. Paramedics are expected to work, for example, in an uncontrolled environment that is sometimes dangerous. A person who is unwilling to enter a scene until every risk has totally been eliminated is not acting in accordance to the expectations of the profession. Conversely, a paramedic is expected to refrain from entering a hazardous area until the risks have been made manageable. Common sense would help in resolving the conflicts such as these. There are instances where we are told and are expected to enter a scene that is not 100% safe. And that goes against what we have been always taught. Even I said that in the roles and responsibilities, that we are our own advocates. We must take care of ourselves and our crew first, and then our patient. However, if that scene, we're never going to eliminate 100% of the risks. And if we take the time to eliminate 100% of the risks, there may not be a patient for us to deal with in the end. How many unsecured homes do we walk into every day that we don't know what's on the other side of that door? We think it's an 80-year-old little old lady that needs help. It may not be. Or it could be a little old lady that needs help, but she's got dementia, but she lives alone, so nobody's seen the progression. She thinks you're somebody trying to break into her house, and she breaks out the shotgun that Grandpa had, who died 10 years ago, but it's still got 2 rounds loaded up in it, and it's waiting for you as soon as you open that door. We can't always see the dangers and the risks, and we walk into them blind. Sometimes we have to walk into them eyes wide open, knowing that this is a risk. However, every opportunity or every bit of attention that can be given to mediating the dangers has been taken. Fire is on scene, and they are watching. They've disconnected batteries. They are throwing down absorbent material to clean up the oil and gas. They are got hose lines ready in case of fire. Whatever the case may be, they are mitigating the dangers for us to make it safer for us to enter that scene and take care of that patient. These are the things that we have to deal with. Another big one is active shooter situations. There may become a time when you are called to go into one of those situations. Services are now providing bulletproof vests and body armor for the ambulances in that respect. We are not any more special than anybody else. If given the proper equipment to mitigate that danger, it is part of our job duties to enter into those areas. And if you are not willing to do this, a street position may not be the best thought for you. Not saying that anybody needs to get out of the field, but you need to really look at what you're willing to do, what you're not willing to do, and you need to make sure that that is in accordance with your local services, policies, procedures, and guidelines, and how that lines up with the code of ethics within your area. We can't always make it 100% safe. We can't always pick and choose where we get to go and when we're called to go into a scene. Some of the fundamental questions, what is in the patient's best interest? Reassurance, relief from pain, prompt and safe transport, a written statement of the patient's desires, reassurance, relief from pain, prompt and safe transport. That's our main job. Sometimes that's easiest. Sometimes it's not that easy. Sometimes there's a written statement of the patient's desires. That patient is unresponsive, on the floor, and they're the wife or family or just laying next to the patient on the nightstand or wherever. It is posted that they do not want intubated. They do not want ACLS drugs placed, or they don't want CPR done. They have a DNR, or they have a living will. Per our local and state laws and our medical direction, depending on what those state, we are obligated to respect the patient's desires up until it becomes whether we're breaking that law or not, or breaking that regulation or statute. These are things that we need to know. That way we can make the proper adjustments, or we can contact the proper people, medical direction, or our administrators, or whatever, to seek guidance in such a situation. Sometimes we don't have time for that guidance, and we have to make that call. That's why we need to know what state and local regulations are obligate us to do, in which of honoring the patient's living will or DNR. You got to be very cautious in accepting the family's description of the patient wants. You got to look at this in somewhat of a suspicious way. What do they have to gain, or what do they have to lose? And who has the most to gain and who has the most to lose? I hate putting it that way, but that really is kind of where you need to be. What do your local state regulations state that you will do in the instance or in the lack of DNR or a living will, and the family is saying, well, they wouldn't want that. They don't want you to do that. How do we know that that's what the patient wanted or doesn't want? When there's a lot of trust there. There is a lot of that you're placing on the family that could ultimately result in the end of your career. The decision you make in absence of paperwork, of a written statement, a properly notarized and signed written statement of what their desires are, could be the end of your career, and in which case, how good are you going to help people then at that time? These are things that need to be considered and need to be planned out ahead of time. And knowing what state and local laws and what your protocols are and what your medical direction wants you to do are all things that guide that decision. fundamental principles of the problem solving and ethics that we use, or bioethics that we use. There are 4 fundamental principles that we're going to look at. Beneficence. Okay, so beneficence is related to a more familiar term, benevolence. Both come from Latin concerning doing good. However, benevolence means the desire to do good, whereas beneficence means actually doing good. So this is referring to your obligation to the patient. You are there to do good and do no harm, which brings us to malfeasance. Malfeasance means directly doing harm. That also comes into law. That is a legal term as well. Non-malfeasance means doing no harm. Little of what we do comes without a risk. Under the principle of non-malfeasance, however, the paramedic is obligated to minimize risk as much as possible. That means we're not going to do a needle crake or a quick trach when all we need to do is intubate. We're going to do the least amount of harm to do the most good, if that makes more sense. If an IV is available and able to be obtained, why would we start an IO? If we can manage a patient's airway while they're awake and able to respond to us, why would we RSI them without the need? So we need to minimize the risk as much as possible of the treatments that we do that do inherently have some risk. Patients have autonomy, which is they have the right to determine what happens to their own body, including treatments. They can say, no, I do not want that IV. They can say, if they are able to speak, I do not want intubated. If a patient says that, I do not want intubated, what choice do you have? You don't get the choice to RSI them, especially if anybody else has heard them. They have autonomy over themselves. They can choose their treatment, what they want, what they don't want. You have no choice. The only thing you can do is inform them to the best of your ability as to why it would benefit them to have whatever treatment you want to do done to them, and let them make that decision as well informed as they possibly can be. And justice refers to paramedics' obligation to treat all patients fairly. We treat all patients the same no matter what. Again, like brought up earlier, when deciding whether we're going to treat the suspected murder suspect's gunshot wound or if we're just going to let him bleed, we don't get that choice. We treat everybody the same. Doesn't matter that he's a wanted suspect in a murder case. He's a guy that got shot. I don't care who shot him. That doesn't matter either. My job is to plug that hole as efficiently as possible to the best of my ability and get him to definitive treatment. Everybody else can make all the legal judgments they want on him. I'm going to do what I'm there to do and do it to the best of my ability. In resolving ethical conflicts, institutional review boards protect the rights of subjects in research projects. So you can, if your service is part of a research project with a scientific study or a drug study or a procedure study or an intervention study, whatever the case may be, institutional review boards will protect the rights of those subjects that are within the research projects. You have the right to opt out. I know in larger metropolitan areas, if you're in an area with a service that is instituting a study, you have the option and the right to opt out of that study, and they generally give you a little wristband, kind of like one of the silicone wristbands, that you can opt out of, and that is your right. That is giving the patient the autonomy of choosing to be in that study or not to be in that study. And they also to reason out the ethical problems. You cannot count on them to assist you in the field. You need to have a system of resolving these conflicts. You need to know what you can and can't do as far as your legal obligations, as far as your local state protocols, your medical direction, your standing orders, your guidelines, standard operating procedures, whatever things that guide your treatment in the field at your local service. On top of the state laws, knowledge of these things will help a lot in guiding your ethical treatment. And then knowing the EMS code of ethics, if your department has a code of ethics, let those be your guides into resolving these. And they may go against your own thoughts and your own beliefs, but it's not about you, it's about the people and protecting the people that we serve. To help reason it out, you state the action in a universal form. List implications or consequences of the action. It is no different than explaining a treatment to a patient. What good is going to come out of it, what possibly bad can come out of it, and then compare them to relevant values. Does it meet criteria? Does it meet the ethical obligations that you have to your field and to your service and to the patient? Is the current problem similar to other problems that you've already formulated a rule? If yes, follow your rule. If not, determine if you can buy time. Do you have time to figure this out, or do you just need to act? Can you run it past your partner? Use your partners. That's what they're there for. The impartiality test. Would you be willing to undergo the procedure or action if you were in the patient's place? Universalizability test. Would you want action performed in all similar circumstances? And then interpersonal justifiability test. Can you defend or justify your actions to others? These are all things that need to be worked out. If you have the time to work this out, great. If not, this may be something that you just have to follow your gut on. Hopefully this is something we don't run into in the field that you don't have the time to work on this for. We'll work through this, again, as with everything else, this is an ongoing subject. We will cross these things again as we continue through class.